Good evening, everyone, and welcome to this another webinar by ISCCM. And as you know, this is the last webinar of this series, and we have been regularly doing webinars every month on the last Friday, and hope they have been useful to all of you. As a last webinar, we wanted to cover up the most important part of critical care, which is the basic critical care. And as we know, in India, there are a lot of places who really do not have the resources which are available in the tertiary centers or in the metro cities. And so the webinar is focused around that area, that how do we really limit, or here where we are in Mumbai or maybe in bigger metro cities where we actually look at POCUS, we actually look at diagnostic PCRs and take our diagnosis. Uh, we will be now looking at other clinical aspects about how to manage critically ill patients. So we have Dr. Pasha, who is the moderator of this webinar. I will hand it
Hi,
over to
good
him to
evening.
take it further.
Yes. Good evening, all. Our session, our 1 hour session, 7 to 8, the first half will be dealt by two lectures. One is non-sonographic approach to the shock by Dr. Guru Prasad Naranji, and the other session by antimicrobial stewardship in a resource limited settings by Dr. Vanit Kaur. Yeah. Dr. Guru, shall we move on? It's over to Dr. Guru Prasad, sir.
Is my screen visible?
Yes,
doctor. Yeah. So, as Dr. Gunjan and Dr. Sheikh told that we are focusing on critical care practices in Tier 2 cities. The topic which has been allotted to me is a non-sonographic approach to shock. And at the outset, I thank Dr. Gunjan, Dr. Srinivas Samovedan, and ISCCM for giving me this opportunity. So, how do we approach shock in a resource-limited settings? We will be covering this presentation under the following headings. We define shock, then classify it, look at how do we approach shock, talk a little bit about micro and macro circulation, and emphasize early recognition. So basically, as all of you know, shock is one of the commonest presentations in our ICUs or in our casualties. So it is a life-threatening condition characterized by inadequate organ perfusion, which leads to cellular dysfunction and multi-organ failure and potentially death. So what is very important is early recognition and treatment is very crucial. And even when the cause is not immediately clear, so you have to be ready for it. And in resource limited settings, a systematic approach based on the clinical assessment and readily available tools is essential. So basically, you are looking at something, a shock which causes inadequate perfusion, a cellular dysfunction, and if untreated, organ failure. So you can get a patient in any of these stages. So the patient can be compensated, that is in a pre-shock state where he shows tachycardia and peripheral vasoconstriction. Then if untreated at that stage, then he moves into a decompensated state and you find classical signs and symptoms of shock, which I'll explain to you as the session goes on. And if untreated, the patient ends up in end organ dysfunction, which can be an irreversible organ damage, multi-organ failure, and even death. So shock, there are 4 types of shock, which all of us know. One is a hypovolemic shock, the distributive shock, cardiogenic shock, and the obstructive shock. So hypovolemic shock can be hemorrhagic or non-hemorrhagic. So the history is more than enough to for you to know whether it is an hemorrhagic or a non-hemorrhagic. Any patient who comes with trauma or a GI bleed or a suspected ruptured aneurysm, you can always suspect, or a post-surgical patient can be a hemorrhagic shock. Whereas if the patient is presenting with vomiting, diarrhea, or burns, or inadequate intake, can present with a non-hemorrhagic shock. Secondly, the distributive shock. There are types, there are different causes for distributive shock. The most commonest is the septic shock, which is secondary to infection and endotoxin release, causes vasodilatation. Similarly, histamine release can cause an anaphylactic shock, and a spinal cord or a brain injury can end up in a neurogenic shock, and adrenal failure. So this is also another cause of distributive shock. So what basically happens in a distributive shock is, especially in sepsis, there is a release of inflammatory markers like leukotrienes, protease, prostaglandins, causing endothelial damage, and the nitric oxide, which is released from the cells, can cause vasodilatation. So basically, what happens because of vasodilatation, there is low resistance to blood flow, and the velocity is increased. Okay, so basically the blood flow is good in the peripheries, and heat is generated, and this patient, a septic shock patient, is usually warm, and we call it as a warm shock. The other shock is a cardiogenic shock. So basically what happens is it impairs the heart's ability to pump blood, and it can be because of a myocardial infarction, or because of an arrhythmia, or a myocarditis, or a valvular dysfunction. And what happens in cardiogenic shock is, here there is a sympathetic oversurge, and secondary to shock, it's a compensatory mechanism, and the resistance to blood flow is increased. First of all, because the cardia is unable to pump, so this will worsen the shock, and here the blood flow, the perfusion in the peripheries, everything is hampered, and the patient becomes cold and clammy. So in a traumatic or a hemorrhagic shock, or an obstructive shock, or an cardiogenic shock, you can find a cold, clammy periphery, whereas in a distributive shock, you can find a warm periphery. Next is the obstructive shock, and this is again when the cardiac output is impaired due to some obstruction, either intracardiac or extracardiac. Commonest causes can be pulmonary embolism, or a tension pneumothorax, or a pericardial tamponade. So these conditions impede blood flow, leading to reduced tissue perfusion and shock. So when a patient lands in a casualty or in an ICU, so you should be very, very methodical in your approach. So now what you have to do is a proper clinical examination and a careful assessment to know the problem, to gauge the therapy response, stratify the risk, and predict the outcomes. And key questions to be asked is what are the presenting complaints? Commonly, what you see is the patient presents with lethargy, weakness, or altered mental status. These are not specific presenting complaints, but if you should always know what was the event leading to it, like whether there was a history of trauma, or the patient was bleeding through his GI system, or the patient had some vomiting and diarrhea. And also you have to dig a bit of past medical history, whether the patient has got some ischemic heart disease, or if the patient is on some anticoagulants or diuretics, or on some immunosuppressants and beta blockers, because one is it will help you to know the diagnosis, and even it helps you to manage the patient. So now what are the vital so basically you look at the vital signs. So you look at the heart rate, whether the patient is tachycardic or bradycardic. In a patient who is in a neurogenic shock can be bradycardic, whereas most of the other shocks the patient will be tachycardic. Then if a patient is on a beta blocker, even if the patient is in shock, can be having bradycardia. So these are very important history, important things which you have to do to assess the patient. So a patient can present with hypotension. Anything systolic blood pressure less than 90, or a mean arterial pressure less than 65 is termed as hypotension. A patient can be tachypneic because of an pneumonia, or because of some pulmonary edema, and patient can have fever, indicating that the patient may be in a form of sepsis or a septic shock, or the patient can be in hypothermia too. Okay. Then what is more important is, I think any presentation on shock will show this cartoon, the three windows to assess shock. So brain, kidney, and the skin, these are the three windows to assess shock. So if the patient has got an altered mentation, or a patient is oliguric, or the patient has a mottled and clammy skin, then these are clear-cut signs of shock. Any patient who comes sitting upright, you can always take it for granted that this patient is not in shock. Usually the first presentation of shock is postural hypotension, and the patient is always flat, okay, when he comes to your OPD or a casualty. And the other signs like hyperlactatemia, and when you measure a blood pressure, the patient will be in hypotension. So what are the specific findings by shock type? So if a patient is hypovolemic, basically his intravascular volume is less, and what happens is you get a flattened jugular vein, whereas a warm patient with the history of some infection has a septic shock, or a patient who has been exposed to a drug or for some insect bite can land up with urticaria, angioedema, and wheezing, which can be an anaphylactic shock. Or if on clinical examination, a tachypneic patient, if you find that the breath sound is absent on one side or a hyperresonant on percussion, you can think that is a tension pneumothorax. And if the patient has got an elevated JVP or a muffled heart sound, you can think of pericardial tamponade. History of chest pain, you can think of a cardiogenic shock because of myocardial infarction or a pulmonary embolism. So this is a very busy slide, but I'll not touch much upon that, which I have already covered in my previous slides. So every shock has got its own classical features, but most commonly in a hypovolemic, cardiogenic, and obstetric shock, the features are almost the same. So you have to differentiate with the further investigations to differentiate whether it is a hypovolemic, cardiogenic, or obstetric shock. And the distributive shock, again, the septic, anaphylactic, neurogenic. So you can see most of the time the patient is born, except if you see in a neurogenic shock, the patient is bradycardic. And if a patient is anaphylactic shock, he may have itchy skins or a bronchospasm or a laryngospasm or an angioneurotic edema. So skin is one of the largest organ. You get most of the clues when you touch the patient. So if the patient is cold and clammy, definitely this patient is in some serious trouble. So and more you can find by inspection, you can see mottling, and by palpation you can see temperature gradients, and you can also do a capillary refill time. Unlike other organs, cutaneous circulation doesn't have autoregulation, whereas it is controlled by neurohumoral control. And when there is a circulatory insufficiency, the capillaries undergoes a vasospasm and blood shunts to the vital organs. So here what happens is, what you have to look is at the core and peripheral temperature difference. Normally it is about 2 to 3 degrees, but something more is a warning sign that this patient is in some form of a shock. So, and the practical application is temperature monitoring requires, it doesn't require any sophisticated tools and causes minimal discomfort. A simple subjective assessment of warm or cool can identify a reduced cardiac output. Capillary refill time, and another valuable tool to know whether the patient is in shock. It's bedside and non-invasive and non-expensive, but it should be done in a proper way. Whenever you apply a pressure on the distal phalanx, the pressure should be applied for at least 15 seconds at the tip of the fingers, and the refill has to be checked not by a guess. It is always better you use a stop clock to see whether the refill is adequate. And if the refill time is more than 3 seconds in a young patient and more than 4.5 to 5 seconds in an elderly, that tells that this patient is in shock. Okay, and recent trials have shown that capillary refill time guided resuscitation may be superior to lactate guided resuscitation in shock patients. Next is a mottling, which can be obvious, but it has to be looked for, especially around the knee joint. So this is because of the heterogeneous vasoconstriction of microcirculation, and it appears as a erythematous violaceous hue starting around the knee. So there is a mottling score. If it is if the mottling is at the knee of the size of a coin, the score is 1, and if it is extending beyond the groin of that leg, then the score will be 5. So what is the clinical significance? It is most commonly seen in sepsis, and it strongly correlates with the lactate levels and 14-day mortality. Another device which you can use is an infrared based device, similar to a pulse oximeter, where the device differentiate between a pulsatile and a non-pulsatile flow, and the ratio of pulsatile versus non-pulsatile flow, if the value of that is less than 1.4, it is a poor predictor, and it says that there is a poor tissue perfusion. And another very important tool is a urine output. Always look at the urine output of a patient. Normally 1 to 2 ml per kg per hour is a normal urine output. And if there is oliguria, it is a very, very early sign of manifestation of shock, and it should not be missed. If you treat the patient when the flow rate variability in a very early phase, then the patient's response is also good, and you basically avoid the patient to go to the deteriorate, which is not which will really affect the patient. So, but here you have to keep in mind that there may be some confounders like an intrinsic renal disease where the patient may, like a CKD patient whose urine output itself is low, or if he has got a post-renal obstruction, or there are some drugs used for to decrease the which are affecting the urine output. Then you do the routine other investigations like a complete blood count to assess if the patient is anemic, or if you see the WBC counts indicating infection. Then you check the electrolytes and creatinine to know the renal function. Then you have to get a lactate levels done to indicate if there is some anaerobic metabolism, and ABG will help you to indicate an acid-base status. So additional labs can be like ECG. If a patient has come with a chest pain in shock, ECG will definitely give you an indication of an ST elevation MI, or if the patient has got some arrhythmias, then you do some markers like troponin I to look for a myocardial infection, or a raised BNP to know that the patient is in some pulmonary edema because of cardiogenic cause. Then D-dimers can help you to rule out. D-dimers are of negative predictive value for to ruling out pulmonary embolism, and a high D-dimer can suggest means a very severe shock. The patient is in a DIC because of raised fibrin degradation products. Then you can do a blood and urine culture if you are suspecting infection. Then LFT and a coagulation profile to rule out liver dysfunction and coagulation abnormalities, and procalcitonin and CRP can be done. So this is another thing which I wanted to stress is, see, whatever we do as an intervention by giving fluids, or by giving a vasopressor, or by increasing the stroke volume, it is a macro circulation. Whether this when we are treating the macro circulation, whether the same thing is causing some changes in the micro circulation is what we have to see. Because if the treatment of macro circulation doesn't reflect on the micro circulation, then it means that your treatment is futile. So there should be a coordination, or there should be a response by the from the microcirculation for your treatment. If it is not there, then we call that there is an hemodynamic incoherence. So, or you can call it as a decoupling. So, it can be seen during, before, or after resuscitation, and understanding this possibility and monitoring microcirculation or downstream parameters like lactates, or arterial carbon dioxide is also very, very important in the management of shock. So lactate, as you see, is a metabolic product of glycolysis, and the sources can be from the blood cells, RBCs, skeletal muscles, brain, and most of the lactates can be is metabolized by the liver. So if there is a liver dysfunction, you can find high levels of lactate, though the patient is non-shocked. And lactic acidosis is seen because of tissue hypoxia, and that is because of the anaerobic metabolism that happens in the when the peripheral tissue perfusion is very poor. So normal levels of lactates are about 0.8 to 1 milliequivalent per liter, and anything above 2 is called as hyperlactatemia. But every hyperlactatemia is not lactic acidosis. If it is associated with a decreased pH of less than 7.35, then we call it as a lactic acidosis. So hyperlactatemia occurs when the production exceeds the utilization, and tissue hypoxia is the main mechanism leading to decreased utilization of pyruvate in oxidative phosphorylation and increased conversion to lactate. So lactate is one of the markers which is very useful in our clinical context. There can be other causes of lactic acidosis, like following vigorous exercise, following seizures, in carbon monoxide poisoning, as I said, liver diseases. Medications like metformin and antiretroviral can cause lactic acidosis. Toxins like ethylene glycol toxicity can cause lactic acidosis. So these things also have to be kept in mind. So how does lactate help clinically? It is a screening marker used to screen for tissue hypoperfusion, and it is more sensitive than clinical markers like toe temperature. And it also helps in risk stratification. Higher lactate levels correlate with higher mortality. Even a mild elevation predicts worse outcomes in various conditions. And what I wanted to stress is it is not a single value which you have to take. It is a serial measurement of lactates, which is more important. So single values are not to be looked at. Improving lactate levels reflect hemodynamic coherence and effective resuscitation. Just a word about SpO2, though pulmonary catheters are not put often, but it will help in a normal physiology. Normal physiology, increased oxygen demand is met by increased cardiac output, and the body maintains a SpO2 of 65 to 75%. If there is a mismatch, that means that there is a probably the tissue is extracting more of oxygen and the SpO2 falls. And this low SpO2 indicates a demand supply mismatch. But on the contrary, a normal and high SpO2 does not guarantee adequate tissue oxygenation. And what are the conditions you see low SpO2 is in anemia, hypoxia, hemorrhage, or hypovolemia, and when there is an increased oxygen consumption in conditions like pain, fever, agitation. At the same time, you can see an increased SpO2 when if there is an increased oxygen delivery, like you're giving an oxygen therapy or a transfusion is there, or an increased cardiac output. But a decreased oxygen consumption also can lead to increased SpO2 in conditions like sedation, hypothermia, decreased extraction due to cell death. So this is very important. If you should never be happy that the SpO2 is high. So if the patient is, if the BP is fine, everything is fine, and the SpO2 is fine, but the lactates are high, is not a good indication. That means that there is a cell death and the oxygen is getting shunted back without utilization. So more important is what we can do is we can always measure the central venous oxygen, and it can be used as a surrogate for SpO2. So the anatomical difference is in a central venous catheter, the oxygen saturation from the central venous catheter is ScVO2, and what is taken from a pulmonary catheter is mixed venous artery. So there is blood from the upper limb, lower limb, and the coronary sinus in a SvO2. So, and there is a normal difference about 2 to 3% between CvO2 and mixed venous oxygen. That is because of the high oxygen extraction of the brain compared to the lower extremity. But when the patient is in shock, the brain perfusion is maintained while splanchnic and renal circulation are compromised. This makes the ScO2 greater than SvO2. Okay. Anyhow, there is a poor correlation between the SvO2 and SvO2 during shock, but we need more larger randomized trials before recommending ScO2 as a surrogate. The next parameter is the veno arterial carbon dioxide tension. It is of diagnostic value. PCO2 gap is a good marker for evaluating global tissue perfusion, and variation in PCO2 occur faster than changes in lactate levels, making it more attractive in early phases of shock. And it also helps to optimize tissue perfusion even after normalization of the oxygen derived parameters. So VA different, that is the veno arterial carbon dioxide tension, is also a gap, is also a very good marker to guide you a proper resuscitation. So basically carbon dioxide is in three forms, in the transport in three forms, that is a dissolved carbon dioxide, but major part is transported as bicarbonate. And what is the carbon dioxide production equals to the product of the veno arterial carbon dioxide content difference, and it is inversely proportional to the cardiac output. Lower the cardiac output, higher will be the veno arterial carbon dioxide difference. The normal range is between 2 to 6 millimeters of mercury. So if the patient is having an aerobic carbon dioxide production, then the carbon dioxide levels will be, the VA gap will be normal. Whereas in an anaerobic carbon dioxide production, there may be an widening of the veno arterial gap because in tissue hypoxia, increased lactate production generates hydrogen, and this combines with bicarbonate to produce carbon dioxide water. And as I said, the VA carbon dioxide gap is directly related to the production of carbon dioxide, but it is inversely related to the cardiac output. So other investigations like chest X-ray can be done to rule out pneumonia, pneumothorax, or a pulmonary edema, and abdominal X-rays can be of some value, though limited value, to see free air or obstruction. So principles are, management principles are simple, like you see that the patient is adequately oxygenated, you get an vascular access with 2 large bore IV cannulas, and resuscitate with crystalloids and assess the response. So, but the most important thing is don't forget the ABC. See that the airway is patent and the patient's respiratory status and oxygenation is adequate and circulation is stabilized, even if you are not sure what is the cause of the shock. But ABC has to be stabilized, and then you can evaluate the patient later on. So hypovolemic shock treatment is you control the bleeding. If it is a trauma or the bleeding is a hemorrhage is the cause, and surgical intervention if needed, and crystalloids are the choice. And for a hemorrhagic shock, blood products are always better. And if the patient is not responding for your fluid response resuscitation, then use vasopressors. In a septicemic shock, early antibiotics is necessary, then fluid resuscitation. And if the patient is not responding to fluid resuscitation, once you have given enough amount of fluids, then vasopressor is used. And this is what the surviving substance guidelines says, that in the first hour, you measure the lactates, you get drop blood for cultures, give broad spectrum antibiotics, resuscitate the patient with 30 ml per kg of crystalloids. And if the patient MAP is below 65, then you start vasopressors. And even with vasopressor, if the patient doesn't respond, then you can use steroids. Okay, anaphylactic shock is managed. Again, ABC is common everywhere. So you can use IM adrenaline, then resuscitate the patient with fluids and use antihistamines and crystalloids. Cardiogenic shock, again, depends what is the cause. If myocardial infarction is the cause because of the coronary disease, then revascularization to be promptly done. If this because of an arrhythmia, and antiarrhythmic should be used. Judicious fluid should be administered very judiciously, because fluid overload is very, very common. And inotropes such as dobutamine can improve the cardiac output. And if the patient doesn't improve with the dobutamine, you can use vasopressors like noradrenaline to maintain the blood pressure. So obstructive shock, again, depends on the cause. If it is tension pneumothorax, a needed thoracostomy as an initial thing, and then chest tube has to be inserted. Drain pericardial synthesis for pericardial tamponade, and anticoagulation and thrombosis for embolism. So if the shock is undifferentiated, manage ABC, fluid resuscitation, empiric, do an empiric antibiotic, and then do a methodical approach to find the cause for the shock. So in a resource limited setting, a clinical assessment is very, very important. You have to be very good in your clinical assessment. Basic interventions like oxygen, IV fluids, and essential medicines have to be ready, and the cost-effective intervention has to be done. So prognosis again depends on the stage of the shock. If the patient is untreated, then it is usually fatal. If the patient is treated, still there is high mortality in cardiogenic and septic shock. And prognosis depends on the underlying causes, the pre-existing conditions, timeliness of treatment, age, etc. So to conclude, shock can be challenging to classify precisely and is often complicated to manage effectively due to its diverse causes and a wide range of treatment options. Therapeutic approaches that may be ideal for one form of shock could potentially be detrimental for the another. So making the identification of specific type of shock very crucial for successful intervention. Furthermore, having a comprehensive understanding of the physiology associated with different types of shock, along with pharmacological aspects of shock treatment, is vital for achieving the best possible outcome. Thank you.
Thank you, sir, for an excellent illustrative way of explaining the basics of shock, pathophysiology, evaluation, and management. Covering this huge topic with the best understanding in a short time shows your expertise in this field. Without wasting much time, we will move on to the next lecture, Antimicrobial Stewardship in the Resource Limited Settings, by Dr. Vanit Kaur from Patiala. Over to you, ma'am. Yeah, I request the audience to place the questions in the chat box, which will be answered before closing the session.
Good evening, everyone.
Good evening.
I'm Dr. Vanit from Patiala. I'm going to share my views on antimicrobial stewardship in resource limited setup. I have shared few cases that we are receiving in our setup and what practices we are doing at our setup. So what is antimicrobial stewardship and why do we need it? It is needed to ensure the rational use of antibiotics, especially important in resource limited settings, where we have constraints in personnel, equipment, diagnostic capabilities, as well as human resources. Now, why is it important? Why do we need to do stewardship of antibiotics? Because of the overuse, misuse, and rampant use of antibiotics, which leads to antimicrobial resistance, which is one of the most significant challenges in healthcare today. What are the challenges that we face at resource-limited setups and where the people have financial constraints? The first is the limited access to diagnostics. Like at some resource-limited hospitals, the cultures are outsourced at labs at Delhi or Chandigarh, which leads to delays in results as well as treatments. As a result, empiric therapy is often used, which can promote resistance. Then unregulated use of antibiotics, self-medication, inappropriate use, and the most important is improper dosing, which contribute to resistance. Then third is inadequate surveillance, limited data on antibiotic resistance patterns, expensive markers like procalcitonin, and antibiotic qualities like generic drugs are being prescribed. We try to use the drugs that are of good quality, but these are the factors that we face in the resource-limited setup. Now, what are the core elements of antimicrobial stewardship? The first is the leadership commitment. Leadership support is critical to the success of antimicrobial stewardship programs. Resources must be allocated to personnel, financial, and information needs, and the program should report activities to senior executives and the hospital boards. Second is accountability. Program leaders who will be responsible for program outcomes must be identified. Then pharmacy expertise has to be included and identified. Action. One or more actions should be implemented by the program, which includes perspective, audit, and feedback, pre-authorization, and facility-specific guidelines. Then tracking. We have to monitor the antibiotic use as well as the resistant patterns according to the local ICU, whatever you are using, or the local antibiogram. Then reporting. Report information on antimicrobial use and resistance regularly to hospital personnel. Education. That's very important. We have to educate clinicians as well as patients about antibiotics and the optimal use of antimicrobials so as to avoid the resistance. How do we do it? The first is we have to identify the pathogen. That is depending on the source, whether we are suspecting lung as the source, whether we are suspecting urine as the source, whatever source we are suspecting. Then according to that, whether it is we are suspecting gram negative, positive, fungus, or AFP, by having close association with pathologist or microbiologist. Second, before starting antibiotics, cultures, that is blood, urine, etc., have to be sent. Empiric antibiotics based on the resistance pattern of the particular ICU that we are working in. Escalation is done stepwise, and huge emphasis is given on dosing as well as dispensing, depending on the pharmacodynamics and pharmacokinetics of the particular drug. So I have compiled a few cases that we have received at our centers in the last few weeks. The first case is a 70-year-old male, known diabetic, coronary artery disease. He presented to us with dysuria and fever. On admission, the pulse rate was 124 per minute. Blood pressure was 90 by 50 mm of mercury. Respiratory rate 28 per minute. He was disoriented and agitated. So the immediate management consisted of fluid resuscitation, that is isotonic fluid with normal saline or ringer lactate. Second, broad spectrum antibiotics. Since given the clinical suspicion of urosepsis, according to the history, empiric antibiotics were started. Coverage for gram-negative organisms, example is Escherichia coli and Klebsiella, was done. Then blood cultures and urine cultures were sent within 1 hour before starting the antibiotics. Monitoring and supportive care, monitor vitals, oxygen therapy if needed, and blood glucose control. Then further investigation, CBC, blood urea, nitrogen, serum creatinine were sent. ABG, if there is any concern for metabolic acidosis, decay, all the things have to be clinically, empirically ruled out. In our setting, what we do, what is our practice, if we receive a patient who does not have any shock, the first drug that we start is cephalosporin. It can be ceftriaxone, Magnexfort, anything. But if the patient we receive with shock, then we go ahead with piperacillin or tazobactam. And we de-escalate after the culture report. In this case, it's important to rule out acute myocardial infarction. So old patient, known cardiac disease, that is very important that we rule out other diseases, cardiac disease, so that the rise of in the TLC can be because of MI also. Antibiotic timing. In our setup, this is the most important thing that we stress on, that within the first hour, we have to send culture, and empiric antibiotic therapy has to be started within the first hour. This is a case 2 that we received last week. This was a 32-year-old female, pregnant, gravida 4, live 1, 2 abortion, 33 weeks. She presented to us in sepsis and shock. She was unconscious when we received her. The blood pressure was 60 by 40 mm mercury on examination and IUD. She has been treated outside for 13 days with meropenem for 13 days, vancomycin for 2 days, and polymyxin B for 3 days. Query because they were suspecting bronchopneumonia. Polymyxin B was started outside because the pus they had sent, the sputum they had sent, it had shown Acinetobacter, which was sensitive to polymyxin B and colistin. After all this, patient was referred outside. When we received the patient was unconscious. She had a central line in situ. Patient was intubated in view of severe respiratory acidosis, which had shown pH 7.1 and PCO2 was 80. On investigation, she had high TLC, she was in AKI and deranged RFT, serum creatinine was around 2. This was the X-ray that we received on the day 1. So we are suspecting here 2 sources. One is the right side, we can see a consolidation on the right side of the chest, and second is definitely the IUD. In this patient, so do we send cultures? First thing, the patient was very poor. We should send cultures, but there was financial constraints. And second, patient had already received very high antibiotics. Patient had received meropenem, vancomycin, polymyxin B. Will we receive anything? Patient was intubated at our center, and second central line was inserted just 6 hours before coming to our center. CT was refused by gynecologist and pulmonologist team considering the baby query. So empirically, we started the patient on piperacillin tazobactam and clarithromycin for anaerobic coverage. Patient went into normal labor after 24 hours of admission and delivered the fetus. Next day, when we did CT chest, it had shown a large cavitating lesion on right lung. Query, which was showing to be TB, query aspergilloma. So we started her on empiric ATT, antitubercular, as well as IV voriconazole. Patient started improving. Urine started pouring. When we received her, the urine output was approximately 15 ml in the first 6 hours. But after the delivery of the fetus and starting ATT as well as voriconazole, her creatinine started decreasing, urine started improving, patient was weaned off, and she was extubated on day 5. So here, I want to emphasize that though we know that the dead fetus was delivered, that was the source of sepsis, but we still have another source of sepsis that is in the chest. Here, we couldn't do procalcitonin because of the financial constraints. Patient was really very poor. So this is I think these are the things that we want to show that we can manage patient clinically with the clinical acumen and with a dedicated team. So we consulted a microbiologist also. Now the patient is doing well and she's on room air now. This is the X-ray on day 3, which is showing that it is improving. So another case that was shifted, a 50-year-old male, he was shifted from outside hospital with diagnosis of pancreatitis. Patient had already received imipenem for 2 weeks, has peripancreatic collection. Now in this, the patient presented to us with temperature 101 degree Fahrenheit on examination. Blood pressure was 90 by 55 mm of mercury. Respiratory rate was 30 per minute. Now the first diagnosis is query pancreatic abscess. Second is sepsis. Third is shock. How do we go ahead with this case? First is aggressive hydration, fluid resuscitation. Then broad spectrum antibiotics. A review of culture guides therapy. Now, as we think the patient is septic and patient had already received imipenem, so we started patient on piperacillin tazobactam. Antifungal agents can be added as there is a prolonged course. But the most important thing is source control. In this, we did CT and CT guided surgical drainage was done, which actually relieved the patient of the shock. Investigation, blood cultures were sent before starting empirical antibiotics. CT was done to assess the extent of peripancreatic collection and to see any abscess, CBC count, LFTs, and EBGs. That are the basic things that have been done. So important is have guidelines regarding what to use. Empiric does not mean everything. We use at our centers, colistins or penems are used only after culture reports. They are not started immediately on the receiving of the patient. teamwork which involves pathologists as well as microbiologists, taking everyone's opinion into consideration. Know the local resistant patterns of our ICU. Like in our ICU, MRSA is sensitive to clindamycin and we get very good results. Monitor the antibiotic quality. Thank you.
Yeah. Thank you, ma'am, for giving an excellent insight on this antimicrobial stewardship by treating the worst cases in a best way. And thank you once again.
Thank you, sir.
We'll move on to our next session regarding our panel discussion, where I'm the moderator. So at the outset, I thank the ISCCM panel as well as Samvedran Srinivas sir for giving me this opportunity. I'm honored to moderate today's panel discussion on a topic that resonates with the healthcare professional globally. That is the strategies to overcome resource limitation in the critical care delivery. Resource constraints are a reality for many of us. Whether it is a shortage of staff, shortage of equipment, shortage of drugs, shortage of ICU beds. In order to just deal with this topic, we are having along with me, we are having an expert panelist, Dr. Anushka Dilani, who is a board certified senior intensivist working at Medical Intensive Care Unit of the Colombo North Teaching Hospital, Ragama, Sri Lanka. And the other expert is Dr. Ayan Banerjee, who's a senior consultant and in charge critical care working at ILS Hospital, Dum Dum, Kolkata. The other expert is Dr. Ram Gopal Kota, who is a senior consultant director from Neuro One Hospital, Trichy. And the other expert is Dr. Sai Prasad, director and senior consultant working at Diamond Super Specialty Hospital, Kolhapur, Mumbai. So today, our esteemed panelists bring the diverse perspectives from the frontline experiences to the policy level insights. We aim to explore the practical strategies, share their real world experiences, and engage with you.
How will you?
Yeah, please, for the audience, please feel free to place your questions in the chat box. Yeah, we'll move on for the session. Let's start. Let's explore the breadth of resource limitation we face. Dr. Anushka ma'am, could you outline the scope of this issue? Yeah.
Hello, everyone, and
Yes,
thank you very much, ISCCM, for giving me this opportunity. So I'm delighted to be with you all in this webinar, connecting from Sri Lanka itself. So yes, the topic is very related to me and the country that I live in. And talking with first-hand experience, what is resource limitation? I would say it's a constraint of the essential medical resources that we need to sustain life in patients who are critically ill. Those are patients who need organ support, and without which they would lose their life. So these constraints could be in many forms, starting from financial constraints, personal, infrastructure, medications, equipment, so on and so forth. But ultimately, what it leads to is mainly patient harm. Mainly, the patient's mortality will go up and their morbidity, they are long because of delayed treatment and inappropriate treatment. Their long-time life quality might go down, as well as it will cause strain on the healthcare staff because there's a lot of work to be done, there's stress, a burden, and there's no satisfaction from the work that they are doing. And overall, ultimately, it will cause a national problem because ultimately, as a country, you lose life, which could be very productive to the economy and all. And also, you lose cost. It's the cost effectiveness also drops with the poor quality treatment. So I would say this is, in a nutshell, what the concept of resource limitation in critical care is. But we will go on to see the different aspects of it as we go along.
Yes, ma'am. Thank you, ma'am, for that comprehensive overview, because your insight set a strong foundation for our discussion. So moving on to the next question. So, because in a constrained settings, how can because we are having the scarcity in our ICUs regarding the beds and staff, how does early triage impact the outcome? Dr. Banerjee, sir. Yeah, Dr. Ayanji. Yeah, am I audible? Yes, Chirag?
Yes, sir.
Yes, yes.
Yeah, am I audible?
Yes, Banerjee sir.
Yeah.
Please.
Thank you, Dr. Pasha.
Yes.
Actually, the question is very pertinent for the whoever is working in resource limited setup in Tier 2 cities in India or in the third world countries. So, in fact, during COVID era, it was an actually eye opener for all of us when the system was overwhelmed with the astonishing number of sick patients. So many of the advanced ICU also became resource limited in Tier 1 cities also. So while working in Tier 2 cities, we should be concentrating on the dictum that we should do greater number of goods for the greatest number of patients while the resources are scarce. So we should train our staffs to do monitoring systems like early warning sign, Muse score, or SOFA score, Apache score to segregate out those sicker patients who needs urgent and utmost care at first, and then reserve the resources for the later one.
Yeah, thank you, Dr. Banerjee sir, for highlighting the importance of this structured triage. Because as you rightly mentioned, COVID, because India faced a severe shortage of hospital beds, oxygen, as well as ventilator during the Delta wave in 2021, where we kept as SPO, most of the ICU has kept us SPO to less than 90, they have to be kept in ICU in order to give the priorities and triage. Thank you, sir. And moving on to the next question, as we are in a constrained settings, how can diagnostic stewardship will reduce the wastage? Dr. Ramgopal sir.
Good evening, Dr. Arif.
Sir, good evening, sir.
Nice meeting you.
Sir, thank you, sir.
And the question is very, very relevant nowadays. And thanks for compiling all the questions and doing a wonderful job. Yes, the diagnostic discipline means what exactly, like, are we looking at the number of tests we are going to do and how many of them are to be can be afforded by the patient A? And second thing is, in spite of the patient not able to afford it, still we have to go ahead because we may be able to reduce the number of ICU days by doing certain tests. Especially, let us say an X-ray for a pneumothorax, or even, for example, like what Dr. Gurprasad has already said, and what Dr. The other person from Patiala, she spoke so nicely about this antibiotic stewardship. And both the factors are very, very important. I just want to say one particular point where you expect in trauma, especially if the patient comes with a bloated abdomen, a 4-quadrant aspiration, a simple test that will give you most of the diagnosis, especially in places where you do not have a CT scan or an ultrasound. Similarly, just a washing of the hands, putting up a full dressed before you put a central catheter, all these things are going to reduce the infection to a maximum rate, which we have seen in our own hospital for the last 8 years. We have been doing this, and washing of the hands is the most important factor. And especially, much more than anything, I feel the stewardship should be not only limited to telling the doctors, it is telling the attendants when they come into the intensive care unit to wear the mask, to wash their hands, and then only they can touch their own patients. This is extremely important, and this has brought down in our hospital, especially for the last 6 months, we have seen the organisms are the same, but they are now sensitive even to simple ceftazone sulbactam type of antibiotics. Thank you.
Sir, thank you, sir. That was an insightful take on diagnostic stewardship. So moving on to the next question, because Dr. Vanit Kaur has already explained in a best way, antimicrobial resistance is a growing global concern. How does this antimicrobial stewardship fit into this resource limitation equation, sir? Dr. Sai Prasad, sir.
Yeah, good evening, Dr. Arif.
Good evening, sir.
So, see, this can be answered actually in 3 parts. So,
yes.
The question is, especially when you have limited resources, when you want to start antibiotic, when you don't want to start antibiotic. The third question is when you want to discontinue or cessation of use of antibiotics.
Yes,
so the question here is, if you have a rapid point of care diagnostics, it makes it simple to differentiate between bacterial viral causes, and it will go a long way in improving antimicrobial stewardship. But limited diagnostics in limited resources setting is an issue. So especially when you have a sepsis with shock, there is no question you need to give antibiotic within 1 hour. But when you have sepsis without shock, you are supposed to look for non-infective causes, and if you can prove that, probably you need not use. But there are issues here in evaluating these patients in limited resource settings. So there probably, if you have a high concern about infection, you go ahead and give your antibiotics. Probably the same thing Dr. Vanith had stressed in her case also. And third thing is, if you have suspecting a parasitic infection like malaria, dengue. I mean, malaria, if you need to use anti-parasitic drug, so you go ahead and use it if you don't have facilities for proving or disproving it. But at the same time, when you don't use it, is when you have a clear-cut non-infective cause, or when you have parasitic infection. So because we have seen people using antibiotics left and right for dengue also, for malaria also. So these things should be really discouraged. And the last part of it is when you want to discontinue, or that is de-escalation or cessation. So here in a situation when you have access to procalcitonin and you can afford for repeated procalcitonin levels, you go ahead and do it. But in our maybe tier 2 cities, probably you go by your clinical improvement and then your WBC, and then you take a judgment about de-escalation and cessation of antibiotics, because this will go a long way in antimicrobial stewardship.
Yeah. Yes, sir. Thank you. Thank you for that valuable perspective, sir, which is practically really challenging to maintain that. So next we move on to the next question regarding this donor identification. So how can we optimize this donor identification and management despite all these limitations? Dr. Anushka ma'am.
So organ donation, I would say it's a very time-sensitive procedure that we have to do. And as countries that have resource limitation, we face many challenges when it comes to identification and management of these donors. So to start off, I would say in Sri Lanka, the main issue is identification of these potential donors, especially in the rural areas. So the main reason behind it would be the lack of education of the medical staff that are there, and their resistance or their reluctance to diagnose brain dead donors, because we only do brain dead donors in our country, and live donors, we don't do cardiac, post-cardiac arrest donations. So they are actually reluctant to do brainstem testing and thereby do a brainstem death confirmation. This is because of the attitudes. I think we all come in this part of the world where we think the same, and our religion and our culture leads us to against this. It's kind of difficult to change the attitudes of not just the lay people, but also the medical staffing. So how we overcome is that we have arranged a national program that is led by the Ministry of Health, which is the governing body in Sri Lanka, and we are doing regional kind of education programs where we actually get involved and teach the medical officers and doctors how to early identify. And also, since there are no consultants in the peripheries, what we do is once they do identify, we have telecommunication and we just guide them as seniors. So it's easier for them to do the, identification. And that is about identification. And there is public awareness is also very much reduced. We don't have an opt-out system. So to get the family's consent after brain death is confirmed is really challenging in our country. And so we have to educate them, and there's no family support system in Sri Lanka. So we cannot support these families for their bereavements. So that has to be established as well. Now, once it is the consent is taken and all that, we have to optimize the patients. Now, the high-income countries use very advanced cardiac output monitoring and things like that to optimize the patient, which we do not have in our countries. So as the previous speaker, Dr. Narayana said, we go by blood pressure, capillary refilling time, the urine output, these simple clinical parameters to see if there's adequate perfusion to the organs that are supposed to be harvested. And then after that, the main challenge we face is to actually do the procurement of the organs. So what we do is we don't have transplant centers, just a few are now being built up. So the transplant team moves on to the rural area, take up the organ, and then they transplant the organ back to the center where they actually transplant. And the other challenges we face, we do not have dedicated theater time, we don't have a dedicated theater staff. So arranging all this, the logistics. Now we have transplant coordinators, which is a good step that we have taken. Now they move all around and try to take everything in line, so successful transplant take place from that point onwards. So these are the main challenges that we face from Sri Lanka. I'm
Yes,
sure
ma'am.
India is doing much
Thank
better.
you, ma'am.
Yeah,
Your
that's right.
points highlights a crucial area of critical care because the training the staff to recognize early donor potential, improving the communication with transplant teams, and setting up the clear protocols, streamline the process even in the resource environment. Like as you said, that is the role of coordinators will have a crucial role. Thank you, ma'am. So moving out to this cost effectiveness. So can you highlight some cost-effective technological innovations for ICU in a resource-limited area? Dr. Banerjee, sir.
Yeah, thank you. Actually, see, in our Indian subcontinent, Tier 2 cities are having extremely scarcity of trained intensivists. So, few technological solutions which can help whoever is on the field so that we can monitor better, we can diagnose and analyze the data better. So that will be surely helpful. So likewise, in the last few years, there has been few technological additions post-COVID era. So like you can say, but tele-ICU which performs excellent. We have seen in the COVID era, by which we can reduce the number of intensivists required at the site of the ICU in the Tier 2 cities. Also, some automated early warning sign can be, which are driven by basically artificial intelligence, which are very much helpful for sepsis, cardiac arrest scenarios, or any respiratory distress going on. And likewise, during COVID era, there are some advent of open source or 3D printed ventilators for extremely resource-scared areas. So that was also that few innovations. And likewise, you can use mobile-based ICU round app for better collection of data and interpretation. So that will be helpful for whoever is on the field in the Tier 2 cities.
Yeah, thank you, sir, for sharing those innovative solutions. Because like telemedicine, portable ventilators, and AI-driven predictive
and also, I would
analysis.
like to stress upon the point of care
Yes.
diagnostic methods rather than relying on bigger machines like CT, MRI, etc.
Yes, yes. So thank you, sir. So moving on to this next slide, please, Chirag. Coming to this ethical considerations, what ethical principles should guide the resource allocation in our ICUs? So, Dr. Ram Gopal, sir.
I think you have put me in a spot, Dr. Arif. Basically, the financial rules in my almost all these resource limited intensive care units. Whether really speaking, how many of of us do have adequate and trained staff nurses to do a good job?
Yes.
And this is one question which I would like to ask everybody. Like I myself, I know that I have to spend 70% of my time in the intensive care units only because I did not have adequate staff who are working in. And at this moment, the presence of emergency medicine doctors have definitely helped us in at least overcoming this to a certain extent. Whenever we are talking about ethical consideration, one point that I would like to mention is, if we know that there is a better treatment available in some other city and the patient can financially afford it, I think it is ethical on the part of the intensivist to refer the patient to the higher center. That is one. And secondly, whenever you are getting a patient, even though the patient can afford and is ready to be admitted, the patient attendants are all willing. If he is at the end of his life, let us say an 80-year-old man who had probably a fracture femur or a cancer disease earlier, should you continue to ventilate him? Should you put him on all these measures that we are talking about I really do not know. I think it is basically what I would do, or rather what I have been doing is only I will put these patients on ventilator, yes, for a day or two, and then I will suggest the attenders very clearly that there is no purpose in treating the patient any further, and we will disconnect with the consent of the patient, and so that there won't be any problem medico-legally to the relatives afterwards. This is what we do. The second thing, whenever there is a DNR order, we should follow it, and that is the basic ethics we should follow. If there is a DNR order from at least one of the treating physicians, no other consultant should come in and say, okay, I want to ventilate till, or I want to do something till the next consultant comes in. See, the biggest problem which you might have already faced, everybody would have faced, is in tier 2 cities, you are not handling the patient alone. You are handling the patient along with some other consultant. And this is where the ethics will be different for both the consultants. That's all, sir.
Excellent. Thank you, sir. As you rightly said, we have been sandwiched between the protocols and as well as the emotions while handling this type of cases. Thank you, sir, for your crucial perspective. So, as you said, the transparency, fairness, and equity are the keys. So, we are moving to the next slide regarding this medico-legal concerns. So, what are the legal risks faced by the ICU team in case of resource-limited settings? Dr. Sai, sir.
Yeah, this is a very, very important question. Actually, to be frank, it's very difficult to answer also.
Yes.
And the question here is, most of the guidelines and recommendations are from resource-rich settings.
Yes.
You have no recommendations or guidelines for separate guidelines for resource-limited settings. And you modify your treatments or whatever and as per your requirement, as per the requirement of the patient, depending on their financial status. So your act of omission or commission, is it really will stand in the court of law? Will you be protected? So for a simple example, I'll tell you, one boy comes with a chest pain, you take an ECG, and for the sake of, because he's young, you clinically feel it's non-cardiac and ECG is normal, and you don't do his troponins. So unfortunately, it turns out to be MI after 4 hours, and then will you be protected in the court of law? So this is a very important thing. You see, we are modifying thinking in the good interest of the patient, but ultimately, will we be in trouble if something happens? So this is a very important thing. So my concern here is that unless we have a clear evidence-based recommendations for resource-limited settings, where you can do this set of things, you can wait for this set of things. So it is very risky to make our own judgments and decisions. So I am very clear about it. I mean, if anybody wants to comment on this, you can please.
Yeah. Because you're rightly said, sir. Because in our resource poor settings, so because we recently had one case, as you said, is a young chap, 21 years old young chap, who is a drug addict, who has been admitted in the psychiatric altered sensorium. We have been taken care of for a period of 1 month, treated by all the teamwork. They have been alleged in the court like we have removed their kidneys.
Yeah.
So with the proper documentation and with all the teamwork, we could able to save from this case. So yeah, as you said, thank you, sir, for that legal insight. So moving on to the next slide, please. So regarding this burnouts, so how does these burnouts? Are these burnouts and attrition rate is more in case of this resource poor area when compared to resource high areas? So how does this burnout affect the ICU team? And what interventions will help us? Dr. Anushka ma'am. Ma'am, if feasible, kindly a bit louder, ma'am. I think there is a problem with the speaker, it seems. Thank you, ma'am.
Okay, I'm sorry. So yes, burnout would be much higher in resource limited backgrounds where compared to resource rich backgrounds. Burnout because of mainly it's because of the personal resource limitation, and there would be more work for the limited staff that is available there, and this would lead to stressful work overworking and long extended hours and dissatisfaction ultimately, because there's high mortality and there's no moral obligation or moral stimulation to continue work. And you lose yourself, you lose life, and ultimately it causes burnout and fatigue in these working staff. So how do we overcome it? So yes, it's not easy, because we are still resource limited, and how to keep your medical staff happy is the question here. So we can do things at an organizational level, maybe. So we can maintain staff to patient ratios at an acceptable level, and also we can arrange rotational schedules, so that when doctor works a few days, he can get an off period, a vacation period afterwards, so he can rest in that period. And also have a little bit of staff, extra staff, maybe not specialized in ICU care, but to take over while the doctors or nurses take a break during their shift, so that will help them out. And also give them a bit of psychological support, because we don't know, maybe they are in depression, they're suffering from mental depression kind of, and there's no help to be offered for them. So to setting up a mental confidential mental clinics or helplines, that would be helpful. And also debriefing sessions after critical incidents and talking as groups might help also. And making resources available for them, basic facilities, having restrooms or a pantry to have a chat or to have a snack, that might also help. And have a supportive leader that would understand your problems and then address them, and make an appreciative surrounding rather than criticism and all that. Bleeding that around in your staff members, that might also help. So that is from an organization level. So as a policy, you can have a policy to delegate more financial aids to these areas, so that they can be implemented, so the designs are better formed, and you have more the medications and all the restricted medications, the equipment are supplied continuously, so the dissatisfaction or the frustration that would lead to because of the lack of these will be reduced in these staff. And also if you can take the burden off from these people, if you can maybe you can use telemedicine, so that will reduce the workload for your for the personnel, or use electronic medical devices, again which a little bit of AI, if we can use it, so that the burden for the staff will be reduced. And as an individual also, if you have a role, so being happy is a choice. So you can use your time to ensure that you have a good physical wellness, a mental wellness, and psychological wellness. Meditation, having hobbies, these might help, or having a fun time with the staff that you work with, that might also help you around. And also having a professional development, you make sure that you go up in the ladder of education as well, so that gives you a sense of achievement at the end, and so that you will not feel burnout afterwards. So these are the simple things that I thought of, like that would help to prevent burnout in our settings, in our side of the world.
Yes, ma'am. As you rightly said, that stress management training will also help in this staff well-beingness. Thank you, ma'am. Your points highlighted a major challenge. So moving on to the next slide. So as you said, there is the role of artificial intelligence. So how can an artificial intelligence assist in ICU management? Dr. Banerjee, sir.
For the last 1 or 2 years, we have been seeing that artificial intelligence, AI, and machine learning is very much in.
Change the slide, please.
Yeah, and I would say rather next decade, it will come in very much incorporated into our system, healthcare system, and obviously critical care is going to be benefited out of it. So basically, for us intensivists who are working in the resource limited setup, data analysis and predicting the outcome beforehand would have been very much helpful, because there are less number of trained staff on site. So in that scenario, AI comes into play. So basically, AI model, algorithm, whatever it is, it analyzes the patient data very well, and it with the big data, they take the out of it machine learning, and they implement it, triaging the patient better than those in the resource, whoever is working in the resource limited setup. And also clinical decision making becomes much easier with the advent of AI. So resource allocation becomes very much easier. We also where there is a scarcity of ventilator or life support system, so where to allocate properly, that can be guided by AI also. Those are the few directions that where AI may be very much helpful for us.
Yes, sir. Sir, what do you think, sir? At this junction, what are the barriers to this AI for resource poor area? Is there any barriers? Hindrance?
I did not get you.
Yeah. In order to implement this AI, whatever you said, is there any barriers at this moment?
A barrier at the technology, whatever new technology is there, so you have to learn it quickly. So and get adjusted to it. So I think that much of training, those whoever see, for us a bit younger generation it is easier, but for older intensive it will be a bit difficult.
Yeah, truly said, sir. Thank you. Sir, moving on to the next slide. What will the role of this partnership play? Chirag, next slide, please. Will the partnership play in improving this ICU resources, like the collaboration between the private, public, and non-private sectors? So, Dr. Rangopal, sir.
From my own experience, both as a Rotary Club member and as well as an intensivist, I remember an incident that has happened where the Rotary Club has donated about 18 lakhs to an ophthalmic hospital in this city. And it was when the Rotary Club members wanted their own attenders to get it done, get the tests done, importantly, it was refused. So this is what that has happened.
Yes, sir.
So to what extent it will work, unless there is a mutual relationship and a mutual understanding, this will be a very difficult thing to happen. Like nowadays, let us say, most of the hospitals which are having reasonably good intensive care units, even though resources are not that good, they have to spend money, especially if they are a limited company, they have to spend money on corporate social responsibility. So you choose a place, another hospital or another place where you are spending your hospital's money, and from the other hospital also can choose you as a partner, and thereby both the hospitals can be benefited and the patients are benefited most importantly. That is one of the things which we are doing in our hospital. We have chosen a place which is in a very remote place of Tamil Nadu, and they do send patients to us, and we go and do services to them, and that's how that relationship has grown over a period of time. The other thing that we are doing, rather anybody probably can do, is our senior consultant in neurosurgery. He has started a trust, and he donates part of his income to that, and a part of it goes to the patient from our hospital who cannot pay the bill. So these sort of donors are there everywhere. It is our responsibility to identify them and talk to them and get them into your hospital's scenario and show them what are all the things that you are doing for the poor patients, and that is how you can do the things. As far as the government is concerned, a private hospital cannot have a government association either in Tamil Nadu or in Andhra. I don't know about other places. It is the government will not allow it. The only time whenever some amount, some relationship was there between private and government officially was during COVID.
Yes.
Was during COVID. That's all I can say. Thank you.
Sir. Yes, truly said. This is one of the major components where if there is any collaboration between this private and public sector, there will be more helpfulness for the society, sir. Thank you, sir. And moving on for this next question regarding the policy measures. Sir, what policy measures are most effective in addressing this ICU resources gaps? Dr. Sai, sir.
See here, I think the government should invest in education and research activities in Tier 2 cities, because the more data and information should come from these places. So then only you'll be in a position to make your own decisions, and it will be legally also valid. Second thing is the research in these resource limited settings. They should focus on quality improvement as well as cost effectiveness. Lastly, the most important thing is investing in technology is not financially viable in Tier 2 cities. It's other way around in metros. So for government should give incentives for investing in newer technologies and gadgets for Tier 2 cities, hospitals, or group of people who are all doing these kind of activities. Because otherwise, they are on their own, they'll not be financially viable. Maybe like tax rebates or GST rebates. So these kind of things. Unless these things are promoted by the government in Tier 2 cities, they will not have access to newer modalities. So this is very, very important. And then research is also an important thing to include these Tier 2 cities to make more data on this.
Yes, sir. Yeah, as you truly said that increased ICU funding, workforce incentives, and the streamlined procurement policies improves the resource availability. Thank you, sir. And we'll just let's conclude with this practical takeaways. Could each panelist share one key strategy, sir? Starting from Anushka, ma'am.
I would say the resource limitation.
Change the slide, please.
Yes, the resource limitations that we face as India, as Sri Lanka, and other countries, are going to be individual, different from country to country, even within region to region. In our case, it's different between hospital to hospital. So I would say how I would tackle it is go work at your place, identify what is the resource that is lacking in your center, and work and try to work around it to overcome that burden. While you fight to get your resources, you also try to work with whatever facilities you have to get the optimum for your patients. Thanks.
Yes, sir. Next, yeah, Dr. Banerjee, sir.
Yeah. Actually, till last year, I was attached to one big hospital in a Tier 2 city in West Bengal. So that was an eye-opener, but I was fortunate enough to do my work very well, but because this hospital was well-resourced. So I did not face that much of difficulty. And now I am working in a Tier 1 city with the limited resources. So this is other way around. But according to me, 4 T's are very much important. Like triage, effective triage should be very much important if you want to segregate your resources well for your patients. And also ISCCM as a society should invest more in training these Tier 2 people in intensive care, because we need more and more people who will be trained enough to do learned decision in intensive care. And new advent of technology, as Sai sir already told, that it should be made cheaper in Tier 2 cities so that we can implement it there. And teamwork is very much important. It is multidisciplinary work. We all know that critical care is multidisciplinary game. So a patient cannot be saved without help from our learned colleagues from other specialties. So these are the 4 T's which can be very much helpful while running our show in Tier 2 cities.
Yes, sir. So, like Dr. Ram, sir.
Very well said already by both the 2 consultants. I don't think I have anything more to add except that the management and the consultants are
so kind of you. Dr. Sai, sir.
Yeah. See, actually, training our staff, monitoring simple clinical parameters and using your resources very judiciously, this will go a long way in improving our outcome. But one simple example I'll give for especially high-end technologies, cooperation among hospitals in tier 2 cities is very, very important. For example, we have bought an ECMO machine,
Yes.
5 hospitals together. And we have trained a group of staff, 2 from each hospital. So wherever it is required, our group will go in all these 5 hospitals and we put the patient on ECMO. So it's very difficult for a single hospital in a tier 2 city to buy an ECMO and train people. So this kind of cooperation among hospitals in tier 2 cities will go a long way in improving the outcome among patients. Thank you.
Yes. Yeah. Before concluding, going to the questions, we'll just have some. Dr. Guruprasad sir want to say something.
Yeah,
Sir, Guruprasad sir.
Yeah.
Yes, sir, please.
I've been listening to all these things about resource limited setting.
Sir.
I think all the hurdles or obstacles what we are thinking can be easily overcome. Whereas, in fact, being in a smallest of the smallest town, we are doing critical care what is done in bigger towns. I can tell you that. Only thing what we don't have is an ECMO. So one is teamwork. Okay. So we are 4 anesthetists who joined in 2015. Now it is 10 years. We are successfully running, and we are we are there 24 hours. It is covered 24 hours by a consultant, and till today there has been no litigation. 1 or 2 people who have done some issues, they have been thrown out of the hospital. So the basic problem is there should be a consultant round the clock. And as I said, your mind game. If you know that you can overcome anything, it is possible. Nothing can stop you, except your mind. Okay. And with internet around, no place is big, no place is small. I can vouch on that we are totally updated, like how we are, how people in the bigger cities are. Thank you, sir.
Yeah. Yes, sir. I think we are having a couple of questions, sir, before concluding. Yes. Want to say about, like, okay. Are there any clinical markers or guidelines to start on antifungal therapy? Like Dr. Vanith Kaur, ma'am.
Dr. Vanith, are you around?
Yeah, anybody, any panelist, yeah.
So maybe I'll take that question.
Yes, please. Yes,
So
please.
there is no really a great clinical marker. There are quite a few like beta glucan and everything, but I think they would not be available in tier 2 as well. So if you look at what we did, I mean, I have worked in a tier 2 city for some time due to some personal reasons. And what we would really do is look at a procalcitonin level, which was lucky, do a candida score actually to initiate with, because procalcitonin level in our unit would take 2 days for the report to come. And of course, an empiric starting of the antifungal therapy would what we do. Another thing that helped sometimes was doing a fundal examination, which kind of helped. Okay. And I think Dr. Manimala Rao wants to pass a comment. In the meantime, Dr. Vanith can take the question. I mean, give the answer and we can upgrade her to panelist. Are you there, Chirag?
Yes, ma'am.
Chirag, please upgrade Dr. Manimala Rao to panelist, and in the meantime, Dr. Vanith can answer the question.
Yes, Dr. Vanith. Yeah, unmute कर लीजिए ma'am. Vanith Kaur ma'am.
Dr. Vanith, there's a question for you.
I think she can't hear too.
Unmute कर लीजिए ma'am. Vanith ma'am.
Dr. Vanith?
Yeah, unmute it.
No, she can't listen to us.
अभी सुनेगा. Yeah.
Dr. Vanith, there's a question for you.
Yes, ma'am.
There's a question for you. What is the clinical way or what is the clinical marker or guideline that you use to start an antifungal therapy? Is there anything?
See if the patient has prolonged outcome, patient has been in outside hospital for more than 12 to 15 days, or there are factors like if patient is immunocompromised. We receive a lot of patients that are on chemotherapy treatment. and we receive them in a terminal stages. If the patient is having had been on chemotherapy treatment, these are the guidelines that we follow for starting antifungal therapy.
Yeah, Manimal ma'am wants to say something.
Is she there?
Chirag?
Yes, sir.
Yeah, ma'am को कुछ ये हुआ क्या अंदर आया क्या? Have you taken inside?
In the meantime, I have a question for the panelists. I have been listening to the whole discussion and
Yes.
it was fantastic. I mean, of course, the talks were amazing too. And I learned a lot in this process.
Yes.
The
We
question is,
learned.
where do you place tele-ICU today for reaching out to this tier 2 cities? Of course, ISCCM is doing a great job by educating, by spreading awareness. But where do you place tele-ICU today for improving care at the tier 2 level?
Certainly, it has a major role to play, Dr. Kunjan. It has its future. It is going to come in a big way. It's a matter of time.
No, but will it really make so much of difference? Because you have the trained staff, personnel available in most, even remotest of the places.
I would like to answer that question, sir. It may or may not make much of a difference. It all depends upon the quality of the intensivist who is handling the intensive care in a resource limited setting, because I have seen a good number of intensivists who are damn good in their work, who are working in tier 2 cities.
And most of the ICUs, even in tier 2 cities, are managed by qualified intensivists.
Yeah, you are right.
Yeah,
but this is but what I feel is this is something which is going to come, just like AI, just like something else. It is going to come. See, it is to basically to satisfy, not basically, but it is to satisfy yourself that your diagnosis, your management is right. And second is the patient attender is quite happy that patient is being seen by a secondary consultant.
No, but you know what? When you have tele-ICU, mainly what you need on the ground is skilled people. They may not be critically care trained. They need to be skilled to do procedures. But most of the decisions are taken by the cloud person who's there on the tele-ICU side. So yes, we can reach out to people much more, of course. And if we have innovative ideas like yours, where we can arrange ECMO between multiple units, it is really a boon.
Yeah, and we have to think of this in bad cases. What is the role of this medical legal concerns? The legally also we have to think.
Yeah.
Who is taking that brunt on their side?
Yes.
So
tele-ICU is quite legal. Tele-ICU is quite legal. It's not illegal to run a tele communication or tele unit. Especially after COVID, it has its own laws, but it's quite legal.
As Dr. Gunjan said, training your staff, be it your nursing staff or your class 4 workers. We in our place, everybody does a CPR. Everybody does a CPR. It's not only the doctor. It's a nurse. It is a lab technician. It is a receptionist. Whoever is free. So you basically have to train your own people. You should spend time with your staff to do that, which most of them don't do. They just do their work and go out. It is not like that. It is, you have to train. And one more thing, what I want to tell is update.
Yes, educate and update.
Yeah, you have to get updated, and you will never be inferior to anybody.
Yes.
I would like to add something, sir. In my center, everybody can intubate.
Oh, wow.
Right from the theater technicians to the staff nurses in the intensive care unit, we have provided with the video laryngoscopes with every one of them. We have provided and we have trained them, and everybody can intubate.
Then it is not resource limited.
Yeah, I don't have an ECMO.
That's what I told Dr. Ayan. Resource limited is in the mind. It is not in the place.
Yeah. I think we got another question by Pramodini. Can anyone throw some light on access to well-equipped ambulance to shift the patient to higher centers in resource-limited ICU? Is ISCCM working on it?
Sir,
can I answer that question?
Yeah,
can I answer that question?
Yes, please. Yes, please.
So, regarding ambulance, again, it is how you plan in it. So, we have got an ambulance. It's a small ambulance, actually, a Mahindra Supro, but it can transport a patient on ventilator for 400 to 500 kilometers. Okay, this small ambulance, I got it fabricated in a proper place where I can keep ventilators, infusion pumps. I have put a camera in that, which I can monitor the patient even when the patient is away. Actually, now we had some critical incident, like the stretcher of that ambulance was not working. Okay, so to overcome that, I paid 3.25 lakhs for just a stretcher, imported furnace stretcher, which is getting fitted now. So everything again is you have to spend, you have to invest, and you don't look at the return on investments, because life is the biggest return on investment of somebody. Okay, if I am investing 3.25 lakhs, I'm not expecting 3.25 lakhs in 1 year, 2 years or something. If I can prevent one fall, that 3.25 lakhs is enough for me.
Satisfied. Yes. Justified. Yes.
So ISCCM is working on position statements for transport of critically ill. So so that we can have clear guidelines or clear statements on regulations on how they need to be done. About providing ambulances to every place, I don't know how it would be feasible for any person to provide it to all two-tier cities.
Yeah, like mobile critical care units. Like,
Yeah, but there is airlifting ambulances which are available now, which go to any two-tier city to lift patients to a better center. I hope that answers your question, Dr. Pramod.
Yeah, regarding Manipal ma'am, कुछ बोल रहे थे. Chirag?
I think she's not there. She's left the
Acha.
meeting.
Yeah, I think we have moved these questions also. Yeah.
And ambulance is not expensive. The smaller ambulance you can get for 8 to 10 lakhs.
Yes, yes.
True.
Total
Yeah,
cost would be
conclude
about
It's
20 to
again about
25
the
lakhs.
trained personnel who takes the
Who
personal
takes that?
ambulance.
Yes. Not the ambulance. Yes, not only the ambulance. Yeah.
We can
So-
share the ambulance between 5 hospitals.
See, there are ambulances which say it is an ICU ambulance,
Yes.
but when you get into that, nothing is there. Okay, nothing is there, and ventilator is there. Patient is on ventilator, but all the alarms are beeping.
Yes.
The flow sensor alarm, the oxygen
Yeah,
alarm,
that's
everything
really
is
true.
The basic crux of survival of any critically ill patient is actually a good critical care.
Yes.
A basic
Yeah,
rules like being attentive at the bedside, knowing what you're doing, even if it is the simplest ventilating an asthma patient who doesn't require ECMO.
Yes.
ECMO is not good critical care. Good
Yeah,
critical care is using your hand wash,
Yes.
preventing your hospital-acquired infections,
Yes.
preventing DVT and pulmonary embolism. And
Yes.
I think that would save many of patients. Maybe
Yes.
ECMO, lack of ECMO may risk one life, but not doing good critical care would risk many, many lives.
Yes.
So that is the
Like,
main
that is the
thing which we
crux of the
shouldn't
thing.
forget.
Yeah.
Very well
Yes.
said.
In fact, Dr.
Very well
Gunjan has visited my ICU, and I still remember whenever I touch an ultrasound probe to wash my hands with the sterilium. That day she was very correctly when I touched the patient with the probe, she told that, Guru, did you wash your hands with sterilium? And from that day, every time I touch a probe, sterilium is in my hand. Thank you, Dr. Gunjan.
नहीं, as you truly said, बेसिक ट्रांसपोर्ट जो एम्बुलेंस है उसमें ऑक्सीजन की कमी हो रही है अभी बीच बीच में, बिकॉज दिस वाज रियली हैपन इन माय लाइफ. मेरे मदर को शिफ्ट करने के लिए 3 एम्बुलेंसेस ट्राई किया, बिकॉज आई चेक इट व्हेन आई आस्क्ड द ड्राइवर, ही टोल्ड एम्बुलेंस द ऑक्सीजन फुल सिलेंडर सर बोल के. सर व्हेन आई वेंट देयर द ओपन किया तो कुछ भी नहीं है. सो इतना पैथेटिक सिचुएशंस वी आर गोइंग टू फेस in between.
This is India.
I have kind of confidence on my ambulance. I shifted my uncle from a best possible city to my place and on a ventilator just 2 weeks back.
Yes,
it is basically conscience, and you should have a good conscience telling that you are doing the best. And no patient is different. Everybody is the same.
Yes.
Everybody is a VIP.
Yes, really. We think we are moving out of time. Can we conclude, Dr. Gunjan?
Yeah, we'll conclude.
Thank you to our esteemed panelists for their invaluable insight and to our engaged audience for participating in this vital discussion. So let's continue working together to ensure every patient receive the best possible care regardless of constraints. It's over to you, Dr. Gunjan. Thank you.
Thank you once
one
again.
thing.
Yeah,
I want to
Dr.
add one
Vani.
thing.
Yes,
That
please.
in our ICU, we have just stopped putting tap water in everything. After that, we have seen that we have reduced lot of resistance and lot of fevers. Like even for the oxygen, we use only Bisleri water. For hands washing also. And after that, we have seen quite a reduction in the fever, VAPs and everything.
That's
Very good
We
point,
saw some
madam.
studies
Very
also,
good
but
point.
from the last 5-6 months, we tried this thing and it has really helped.
Just another correction from the RO system, that's all,
yes, yes,
which you are using for dialysis.
yes,
Fine.
yes.
Yeah. But it is actually not recommended now to use any water in humidifiers after the COVID pandemic.
Yes, yes,
We should keep them without the saline, or maybe we should change it more often.
yes.
Yes, sir. So I think thank you very much for sparing your precious time. And last 12 webinars have been quite informative and educative for all of us. And I hope the ISCCM members have also benefited by this.
Yes.
I would like to acknowledge our current president-elect and to be president, Dr. Srinivas Samavedam, for giving us this opportunity. And very consistently, last Friday of every month, we have done webinars for the last 12 months covering varied topics. And I really want to thank the ISCCM members who were a patient audience attending these webinars in huge numbers. And of course, all the speakers, panelists who have spared their time to teach or to spread the knowledge. So thank you very much, everyone. And we conclude with our last webinar for this year. And next year, the new president-elect will take this forward. Thank you from me and Dr. Pasha, who have been coordinating these webinars over the last 12 months.
Thank you. Thank you, madam.
Thank
Thanks for
you.
giving me the
Thank you,
opportunity.
sir.
Okay,
Thank you
okay.
all.
Bye-bye. Bye-bye.
Thank you, audience.
Thank you.
Thank you, Chirag and Aditya, the whole ISCCM team behind us.
Thank you, sir. Thank you, ma'am,
Thank you.
for giving the opportunity.
Yes, thank you.
Bye. Thank you.
Good night.